Good afternoon. This is Dr. Douglas Miller. I am a clinical professor in the Department of Pathology and Anatomical Sciences at the University of Missouri School of Medicine, and I've been invited to speak today about the histopathology of meningiomas to give an update on grading criteria and their relevance to patient outcome, and also to speak briefly on some unusual histopathologic variants that probably neurosurgeons should be aware of in case one of their patients gets one of those diagnoses. I have almost nothing to disclose. I will say that many of the photomicrographs and the other illustrations in this talk are taken from my textbook, Modern Surgical Neuropathology, published by Cambridge University Press in 2009. And that's copyrighted by me, and I derive small royalties from sales of the book. This is something I have pretty standard these days. So in the United States, at least, our CME requirements require that I put in something here. So people who've listened to this talk and seen the pictures will be able to apply the current WHO grading criteria, understand the published data behind them to some extent, and know the prognostic importance of that grading, and will become somewhat more familiar with some of the unusual variants of meningioma. So why talk about meningiomas to this audience? Meningiomas are clearly among the most common of intracranial tumors, and the WHO suggests that they account for from somewhere around 24% to perhaps 30% of primary intracranial tumors, so leaving aside all metastatic disease. The majority of these tumors, the vast majority, are benign tumors, and they have virtually no capacity to metastasize to other body sites or in the CSF. These tumors are easily recognized by neuroimaging, whether CT or MRI, and by most pathologists histopathologically in most cases. And most of these are treated by neurosurgical excision alone, because gross total excision, we'll talk about that a little, should be curative for the large majority of these tumors. While most meningiomas fall into one of three main histological patterns that are readily identified by almost any pathologist, there is a very large range of other patterns which one can see, and some of these are not easily understood as meningioma until one has some experience with them. And that's something that I've already mentioned once and we'll try and point out as we go through the talk. Now, a minority of these tumors, and according to the World Health Organization book, about up to 20%, but in my own experience, which is pretty large, it's more likely closer to 5%, are what the WHO terms either atypical, which they grade as grade 2 instead of the ordinary meningiomas, which are grade 1, or as anaplastic, which is synonymous with what used to be called malignant meningioma, and carries a WHO grade of 3. And these minority tumors that are atypical or anaplastic have a much higher frequency of local recurrence despite gross total excision. And in the anaplastic cases, can metastasize to distant sites by hematogenous means. So these are, in fact, malignant. They are cancers. A correct identification of the more aggressive examples and of those histologic patterns which are unusual is therefore an important task for pathologists, surgical pathologists or neuropathologists, and is the main motivation for this talk. So, in general, to just give us a ground floor to talk about things, most meningiomas are intracranial extraaxial tumors or neoplasms, and they grow as lobulated soft tissue masses that are attached to the inner surface of the dura. So they expand the subdural space. They push the brain and the arachnoid, which is between them and the brain tissue, they push it away from where the tumor is growing. And the pictures I have here are two illustrations, both from autopsies. On the left, a coronal section through a frontal lobe showing a falcine meningioma that's pushing the two frontal lobes apart. And on the right, an incidentally found meningioma that just is a small nodule about 2 centimeters or less in diameter, stuck to the dura and with a rather smooth surface. We owe the term meningioma historically, as with much else in tumor neuropathology, to the great Harvey Cushing, who first used this name for tumors which had previously been recognized by a variety of other classifications or nosologies all the way back in 1922, is when Cushing published the first use of this term. And as one would expect, a large amount of the foundation for modern pathological analysis and classification of meningiomas derives from the classic work by Cushing and his collaborator, Dr. Eisenhardt, which was published as a monograph in 1938. This is the cover page from my copy of that book. So Cushing was not so generous to Dr. Eisenhart. He said the book was by him with her collaboration. But my understanding is that she was a really full collaborator in this project. And what he did was basically record his own experiences with a very large number of these tumors, what the surgery for them was like, what their natural history was, and what the end results were. I should also want to mention in 1982, the distinguished neuropathologist from the United States, John Kepish, who was Hungarian-born and trained, but who spent most of his career very close to where I am. He's in Kansas City, Kansas, just about 120 miles down the road from me. Dr. Kepish published his account of meningioma pathology as part of a series of monographs in diagnostic pathology published by the firm Masson Publications. And here's the cover page of my copy of that, showing that what John was concerned with was biology, pathology, and differential diagnosis. So in that work, John described that there were approximately 65 different histopathologic patterns that one could see in tumors that would still get the diagnosis of meningioma. Some of these would dominate a tumor, and so the tumor would be termed that kind of meningioma, and others might only be present focally in a tumor which had other patterns. And since that publication, now more than 30 years ago, there have been additional categories recognized, including important ones such as rhabdoid meningioma, about which a little bit later. So most of these patterns have no particular prognostic significance. They are not, for example, codified as types of meningioma, therefore, in the official WHO classification book. But a few of these patterns have important prognostic implications. And I think neurosurgeons as well as pathologists need to be aware of these. So going back to Cushing's day, papillary meningioma, a tumor that he described and identified, is a truly malignant tumor, an anaplastic meningioma, with a proven capacity to metastasize to distant sites such as bone, liver, and lung, as well as to recur locally. The current WHO classification, the chapter in the WHO book, is written by Dr. Ari Perry, David Lewis, Bernd Scheitauer, Herbert Butke, and Andreas von Daimler. And that was published in 2007. And that classification recognizes 13 separate types of meningioma and 3 grades of meningioma, which I've already discussed. So grade 1 is the normal or benign ones, grade 2 is atypical, and grade 3 is anaplastic or malignant. And most of those 3 grades apply to all 13 types, but certain types are only found in one particular grade. So that papillary, as I've mentioned, is always an anaplastic diagnosis. So this is a table I put together which just recapitulates what's in the WHO book in slightly different format. So the different types of meningioma are what are called in the WHO book meningothelial, which is derived from the older name of meningotheliomatous, and some of you may know the term syncytial meningioma, and those are all synonyms. So meningotheliomatous or syncytial means meningothelial. The WHO has a category it calls fibrous, it used to be called fibroblastic or spindle cell. And then there's the transitional type, which has aspects of both meningotheliomatous growth and fibrous growth. Semomatous meningiomas are meningiomas that are very much filled with semoma bodies, some of them so much that there's hardly any intervening soft tissue tumor left. And those can almost always be classified as grade 1, whereas the first 3 could be grade 1, grade 2, or grade 3, depending on the particular features that we'll get into to deal with grading. The angiomatous meningiomas, what Cushing had called angioblastic meningiomas, can be of any grade, as can the microcystic, but most microcystic meningiomas are grade 1. There's a variety called secretory, which can be any grade. There's a variety called lymphoplasmacytic rich meningioma, which has some tendency, according to some anecdotal reports, to be more often atypical than not, but that's not entirely clear from a statistical basis. There are metaplastic meningiomas, and I'll describe and illustrate those. And those are tumors that make some other form of tissue, such as bone. There are chordoid meningiomas, which by definition are atypical or grade 2. Clear cell meningiomas, which are by definition also grade 2. And then the papillary and rhabdoid variants are always grade 3. So here are some illustrations of different appearances. In the upper left here, you see a meningotheliomatous meningioma at lower magnification, and then below it at higher magnification. And you can see in the lower picture where the name syncytial comes from, because it's difficult to see the individual cell borders here in the H&E stain section, And so it looks like the nuclei have just been dropped into a sort of a background sea of pink. In fact, there are individual cell membranes, and with focusing up and down or with other techniques, they can be readily visualized. These are not true syncytia, they're separate cells. And you can get a sense that the cellularity can vary without altering very much else. On the right-hand side of the picture are low magnification and high magnification views of fibroblastic meningiomas. The lower right shows that even these can have occasional pneumoma bodies. And the sense you can get from all four of these pictures is that meningiomas are often lobulated, so you've got little groups of cells that are somewhat demarcated from other groups without real capsules around them. And that there's often a pattern, particularly in the fibroblastic ones, of whirling around what becomes pneumoma bodies. That is, the cells sort of, in a static sense, seem to be spinning around a central focus. The WHO recognizes that there are these other morphologic variants that are among the 60-odd patterns that Dr. Peppers described, for example. But in the 2007 book, the committee that put this together, whom I've named for you, wrote that these were currently thought to have insufficient data to indicate that they represented unique variants. And the types of tumor that have been described in various papers and in books about this include oncocytic meningioma, mucinous meningioma, sclerosing meningioma, GFAP-expressing meningioma, which creates an interesting problem sometimes, and something called granulofilamentous inclusion-bearing meningiomas, which I actually haven't seen more than one or two examples of in 30 years. Now, prior to the mid-1990s, meningiomas were largely thought to occur as either benign or quote-unquote malignant. And the benign examples were known to have a substantial recurrence rate, which could be in some clinical series from single institutions as high as 25%, depending on anatomic site. Those at the skull base tending to be more difficult to be gross totally excised and therefore having a somewhat higher recurrence rate. And also depending, of course, on the reporting institution and the surgical expertise of the neurosurgeons at those institutions. The malignant examples were often characterized histologically by pathologists without much reference to actual clinical outcome. And so there are some papers which talk about histologic criteria for malignancy that don't tell you how those patients did, and so you don't even know whether to believe that those tumors were really malignancies. I'll try not to point out those individual papers so as to not embarrass any of the authors. Time has moved on. Now, with the dissemination of diagnostic magnetic resonance imaging and improved neurosurgical techniques that accompany it, the recurrence rate for meningiomas has dropped substantially. The grading criteria for how good a resection is go all the way back to Simpson in 1959, and I think we still have people reporting Simpson grades of 1 meaning complete resection and 4 meaning gross tumor left behind. And so there's still some expectation that the Simpson grade will correlate with whether a tumor will become recurrent or not. But there is still this stubborn minority of tumors, despite our best modern neurosurgical techniques, which can recur despite the fact that they're a gross total excision or a Simpson grade 1 excision. Now, in the older literature, malignancy then has been defined as having, and I'll just quote here, increased mitotic rate, which is not specified as increased over what, or how much is an increase, necrosis in the tumor, which pathologists often think is a bad thing, invasion of the tumor into the adjacent brain, prominent nucleoli, again, not very well defined as to how big a nucleolus makes it prominent, increased pleomorphism, again, increased over what standard and how much is too much, not specified. And this has been refined since the middle 1990s by a series of studies at several institutions, including the Massachusetts General Hospital, NYU Medical Center when I was there, and the Mayo Clinic, and then at Washington University in St. Louis, where Dr. Perry was respectively a fellow and then an attending. And those multivariate analyses have done a much better job of defining the risks associated with particular histological features for recurrence and or metastatic spread. So in 1994, Dr. Tessa Headley-White was senior author along with Dr. Dora Hsu and other colleagues, and they did a study doing mitotic counts in meningiomas and correlating those with recurrence, and defined a category for the first time as atypical meningioma. In the same year, I reported what were supposed to be preliminary studies, although we never got further than these, on a study of a large number of meningiomas examined retrospectively at NYU, and this was in the Neurosurgical Clinics of North America as an invited paper in a volume on meningiomas that was edited by Dr. Joseph Rantahoff. And then finally, Dr. Perry first reported on a study back in 1997 in the American Journal of Surgical Pathology, looking at mitotic counts, which were done with a slightly different method and gave a slightly different threshold, but had the same principle that one could establish a threshold over which one could objectively say this tumor is more likely than not to recur. And this became the precursor of the current WHO criteria. So the current criteria for atypical meningioma are as follows, and this is from the WHO book. Atypical meningioma, or grade 2, is a meningioma with mitotic activity that is defined as 4 or more mitotic figures per 10 high-power fields, that's a 40x objective and a 10x ocular, or an area of 1/1600 of a square millimeter, or 3 or more of the following histologic factors: increased cellularity, meaning very, very high cell density, small anaplastic cells, prominent nucleoli, still unfortunately not very well defined, patternless or sheet-like growth that doesn't have the lobulation I've previously shown you, or foci of necrosis. And so you had to add these up and have at least 3 of these in order to have a diagnosis as atypical using these minor criteria. And the necrosis was always stated that they had to be in the absence of prior therapeutic embolization, which has come and gone and come back again from time to time and from place to place as a popular therapeutic approach prior to neurosurgical excision. Additionally, the WHO noted that tumors that invaded the brain, even if they were histologically otherwise grade 1, had a recurrence rate that was the same, more or less, as histologically atypical meningiomas using the criteria that I showed on the previous slide. And the mortality rates were also similar, and indeed these patients tend to die a little bit sooner than they would if they didn't have these tumors, or if they had only grade 1 tumors. And therefore they said that these should prognostically be considered WHO grade 2. I actually hope that when the next edition of the WHO book is written, that they will be a little less equivocal in how they write this and simply say that brain invasion is a criterion by itself to grade the tumor as atypical or grade 2. The WHO book also took note that meningiomas are well known to express progesterone receptors, and this can be detected with immunohistochemistry, and that if a tumor fails to have such expression, that it will behave more aggressively and has a higher probability of local recurrence. Since the 2007 publication of the WHO book, there have been no fewer than 7 separate large retrospective series showing a correlation with decreased survival and or increased recurrence for meningiomas that are otherwise grade 1 but lack progesterone receptor immunopositivity. So that, again, I would hope that in a newer edition of this WHO classification, that this will be a criterion for calling a tumor grade 2. And in fact, that's my practice. If I have a tumor which otherwise is not atypical but has no progesterone receptor immunopositivity, I change the diagnosis to one of atypical. Now, we don't have a threshold for this. We don't have a number that's something other than 0 or something. So is 1% expression enough to call it not atypical, or 2% or 5%? We don't know that as of today. I can tell you that I'm in the midst of a large retrospective analysis of about 270 cases with a minimum of 5-year follow-up, and we're trying to determine that threshold right now, but I can't tell you a number today because we don't know it ourselves, much less have attempted to publish it. Here, as you can see in just this one photomicrograph, multiple mitotic figures. There's one right here in a late anaphase or early telophase. This may be one or maybe an apoptotic cell, another over here on the lower left, and there are several others in here which I won't take time to search out. So in this one field, there are 3 at least, which probably get you to very close to the threshold of 4. You just need to find one more. This is obviously going to be an atypical meningioma. On the right-hand side of this slide, you see a transitional or spindle cell meningioma, so you can sort of argue about the pattern here. Mostly this is made up of spindle cells that are whirling around some lobulated foci, and there's a mitotic figure over here sort of around 8 o'clock, partway in from the margin. There's another one over here on the right, not too far from the center, towards 3 o'clock. And so clearly here we're already halfway to 4. So this just shows you not very pleomorphic, not very ugly-looking tumors, but that are mitotically active. Now, some caveats about mitotic counts that when you talk to your pathologist as neurosurgeons. The threshold level for a diagnosis of atypical meningioma will depend in part on the ability of the pathologist to recognize a mitotic figure as distinct from an apoptotic or pycnotic nucleus. So one needs to be conservative as a neuropathologist about what one calls a mitotic figure to avoid overdiagnosis. Apoptosis or pycnotic nuclei are actually not uncommon in many meningiomas, and I've seen residents of mine overcount these many times, and I've pulled back their preliminary diagnoses of atypical meningioma and said, if they all look like some sort of odd metaphase, then it's probably not that any of them are actual mitotic figures. Second, the threshold level depends on how you find the mitotic figures, and that gets back to what I was saying about the difference between the counting method espoused by Ari Perry in his papers and the counting method that I used or that was used in the paper from Mass General by Su et al. So what I've espoused as the most objective way of doing this is to use random fields rather than directed searches to look for fields that have mitotic figures. Recently, meaning in the last 5 years or so, there have been suggestions to look for things which would help differentiate and at the same time find mitotic figures more easily. For example, immunohistochemistry using an antibody to anti-phosphorhistone protein H3, which is specifically expressed and active in mitotic cells, but not elsewhere in the cell cycle, for the most part. There are some exceptions to that. We've had some difficulties with those immunostains, and I think other people have as well, and this is not passed into general practice in neuropathology or in surgical pathology and even in other tumor systems. I've also been at pains to point out at times that if we find mitotic figures more easily with these antibodies, we probably need to redo the studies with the counts and adjust the thresholds, because if you find them more easily, you may find one you would have missed in H&E stains. So that's still something to be worked on in the future. These two pictures here illustrate meningiomas which are invading brain and therefore are atypical on that graph. The left-hand picture is a simple H&E stain. The densely cellular meningioma, which is obviously quite blue, contrasts with the pink staining underlying cerebral cortex, and you can see islands of the tumor inside the brain, not apparently connected to the meningioma out on the surface, which is to the lower right. Now, it may be that in 3 dimensions, these fingers of tumor are indeed connected, but nevertheless, this pattern of behavior has been well documented to correlate with local recurrence. These are atypical meningiomas. On the right-hand side, I'm showing an immunostain for synaptophysin. Some people use GFAP when there's a question of, is the meningioma really in the brain? But since what is invaded is almost always cerebral cortex, except for the rare or posterior fossa meningiomas or spinal cord meningiomas, then the most likely antigen to show where there is cortex is not actually GFAP, but synaptophysin, which is universally expressed in the neuropil of cortex. So all of the brown reaction product from the diamine-benzidine reaction of the immunoperoxidase stain is cortex, and you see these nodules of tumor surrounded by brown cortex here and here and down at the bottom. So this is a meningotheliomatous meningioma that has invaded the brain and just as an atypical meningioma. I should emphasize that while individual studies have suggested that one or another type of meningioma is more likely to do this, there's been no there's no consensus, and so meningotheliomatous versus transitional versus fibroblastic versus some of the other types really make no difference in terms of prognosis if they are not atypical, and there's no predilection for any one of those to be more often atypical. So here are some pictures of some of the other possibilities. This is a meningioma, and you have to ask, is this atypical? Because I've centered in the picture a focus with necrosis. This almost looks like glioblastoma in the sense that there's a suggestion of pseudopalisading around this necrosis. The zone with no nuclei lacks nuclei because the cells are all dead. But this one focus of necrosis by itself does not establish this is an atypical meningioma. One would need to go on and look for mitotic figures, brain invasion, all the other things that I have mentioned. But that's just to show you a focus of necrosis. Here is a focus with small anaplastic cells. To the uninitiated or the general surgical pathologist, at low magnification, this might suggest just inflammation, but these cells here are not lymphocytes. They are, if one looks carefully, these are tumor cells. These are meningioma cells, but they're small, they lack much cytoplasm, and these little clusters are the small anaplastic cells that are referred to in the WHO classification as one of the things you have to add up to figure out if you have an atypical meningioma. By themselves, they're insufficient for that diagnosis. Now, some of the variants of meningioma, I have said earlier, are associated more with the diagnosis as atypical. One of these variants, which is relatively recently described in the grand scheme of things, certainly was not known to Harvey Cushing, is what we call clear cell meningioma. So this is defined as a tumor which has cells which look, for neurosurgeons, I get into best analogies, look like the cells of oligodendroglioma. Their nuclei tend to be fairly round. They're centrally placed in the cell body, which has fairly distinct cell borders. And in an H&E stain, the cell bodies don't stain very well, so they look like they are mostly empty, clear cells. Now, some meningiomas have small foci with clear cells, and some meningiomas are dominated by large areas with clear cells. And the WHO has decided in its committees that if half or more of the tumor is composed of such cells, then the tumor should be called a clear cell meningioma. And based on the studies that are out there, which are not very large, because this is not a common tumor type, but based on what's available by anecdote and small case series, these are probably atypical meningiomas, which have a high rate of local recurrence. And there are even a few reports of CSF dissemination to other sites in the nervous system. This half or more has not been scientifically determined. It's a working definition. Here's an example of a clear cell meningioma to neurosurgeons who've seen oligodendrogliomas with their pathology colleagues. This should look familiar, but this is in fact not an intraparenchymal tumor. This is an extraaxial tumor with these cells with clear cytoplasm. And note that not every cell is clear. A lot of the cells have some eosinophilic cytoplasm. But in general, this is the pattern that would produce a diagnosis when it dominated the tumor of clear cell meningioma. And by current criteria from the WHO, this should be called grade 2. There's a pattern of meningioma called chordoid meningioma because the tumor has some resemblance to chordomas. That is, the cells sit in a background with a myxoid extracellular matrix, and they sometimes grow in cords or sheets which look something like those of chordomas. The cells do not have the bubbly pistoliferous cytoplasm of a classical chordoma, and mostly these don't occur anywhere near the clivus or skull base, so there's not really much opportunity for confusion with chordoma in most instances. The WHO classifies these as atypical meningiomas or grade 2 meningiomas based on anecdotal reports of high local recurrence rates. Again, these are uncommon. There's not a lot of statistics out there to show that all of these are atypical all the time, but that's the consensus based on the available data. Here's a histologic view, a photomicrograph of a chordoid meningioma. So you see the cells do grow in these cords in this mucinous background matrix, but notice that the cells don't have the bubbly cytoplasm of a chordoma. This does not really look like a chordoma except in the terms of its overall growth pattern, but not cytologically. Now, as to anaplastic meningiomas, or WHO grade 3 meningiomas, and I'm sorry, that's a typographical error. That could be grade 3 there. I didn't realize that was still there. I thought I fixed it. The primary criteria for a diagnosis of a meningioma as an anaplastic meningioma is a mitotic count of 20 or more mitotic figures in 10 high-power fields. So these are really highly mitotically active tumors. And as I mentioned at the beginning of this talk, any papillary meningioma, going back to its first description by Harvey Cushing and Dorothy Eisenhart, is in fact a malignant tumor, so it should be called anaplastic by current terminology. And the more newly described rhabdoid meningiomas are also regarded as always grade 3 or always anaplastic. Here's a rhabdoid meningioma. You can see, number one, that the nuclei tend to be rather hyperchromatic. So this is a fairly ugly-looking tumor, all other things aside. Notice that the nuclei are eccentrically placed, so they're at the side of the cell body, and the cell body in many cases has what looks like a round eosinophilic inclusion. This is what typifies rhabdoid cells in atypical teratoid rhabdoid tumors of the brain or in rhabdoid tumors of the kidney or soft tissues. Those tumors have a particular genetic abnormality with a deletion of a gene called variously SNF 5 or INI1 or SMARC B something or other. I forget which SMARC B it is. Sorry about that. But the main point is that those tumors have a genetic defect which rhabdoid meningiomas do not. So rhabdoid meningiomas are not rhabdoid tumors which happen to be dural-based, but they are also aggressive tumors. And there is a sort of a theme throughout surgical pathology that tumors with a rhabdoid appearance, even if they are not definably rhabdoid tumors genetically, still are aggressive tumors. Usually, rhabdoid meningiomas will also have very high mitotic rates, may invade the brain, and so will otherwise qualify as at least atypical, if not anaplastic. But by WHO criteria, these are always anaplastic tumors. Interestingly, I've seen some which had a fairly good, at least 5-year survival. But again, that's anecdote, and the statistics would seem to suggest otherwise. Here is a papillary meningioma. So like all papillary tumors, this has a central papillary core with a blood vessel in it, and the tumor cells arrange themselves around this with a more or less radial orientation with the cells pointing into the vessel wall. The papillary structures are not universally throughout the tumor. There are going to be solid areas. Notice this tumor has a little bit of necrosis over here in the lower right of the picture. But if you find papillary structures in a meningioma, that's bad. And we know that these tumors have the capacity to metastasize, that they have a high rate of local recurrence, 80-90% probably, and that these are bad tumors. They are true cancers. And that's been known, as I've said, about 10 times now, back to Cushing's day. Now, there are some other unusual patterns or variants of meningioma that are worth noting, not just for pathologists, but actually for neurosurgeons to keep track of. One of these is the microcystic meningioma. This tumor is characterized by a lot of extracellular space, often filled with eosinophilic fluid, and so might be confused for a moment or two with chordoid meningioma, but it has a very different architecture, which I'll show you in just a couple of minutes. The spaces between the cells are defined by processes of stellate cells. So the cells have long extensions that border these spaces, and that's quite different from what you see in chordoid meningioma. At first glance, these tumors hardly resemble a meningioma histologically, except that if you look at a resection specimen and go through large areas of it, you will usually find one or more foci in which you can find classic meningioma with some whorls or some bodies or lobules with more solid-looking areas. So those help pathologists find these. It is important to note that because these tumors have a high amount of fluid-filled extracellular space, in fact, when Masson, the famous French pathologist at the turn of the last century, 19th to 20th century, when he described the variant of this, he called it meningiome humide, or very wet, fluid-filled meningioma. So that gives these tumors a very high signal in FLAIR or T2 MRI, and so this may also mislead the clinical diagnosis prior to pathologic examination, prior to excision. And this diagnosis should not be confused with diagnoses of gliomas or myxoid sarcomas or other similar histologic mimics. So if your pathologist gives you a very bizarre answer, perhaps it's time to sit down with him or her and just make sure they're not looking at a microcystic meningioma that they don't recognize. So here's what one of these looks like. You see the cells are stellate. They have little processes that go out into the background, and the spaces, which have a myxoid fluid in them, are defined by the cell processes. And so the cells don't associate with each other tightly the way they do in many meningiomas. There's a vague whirling here if you look for it, but in general, this would not pop out as a meningioma to someone just looking at this single field. But if you look through enough of this tumor, you will find areas that will clue in the pathologist that this is, in fact, a meningioma. Of course, it helps to know that it was a dural-based extraaxial lesion within the head or within the spinal canal. Metaplastic meningioma, which you saw the name of in the table at least when I showed you all the different types of meningiomas the WHO recognizes, these are meningiomas which have foci with one or more types of mesenchymal differentiation other than what you expect to see in the usual meningioma. So these can include cells that look like they're adipose cells, lipoma cells, or bone formation, or cartilage formation, or xanthoma cells with bubbles of lipid in the cytoplasm. So again, these should not be confused with chordoid meningiomas when there's a cartilage-like matrix, not to be confused with chondrosarcomas. And interestingly, there is a tumor called mesenchymal chondrosarcoma, which frequently occurs. It's a rare tumor, but when it occurs in the nervous system, it occurs as a dural-based extraaxial tumor, so there is that possibility for confusion. And so this is important to recognize. Here are two examples. On the left is a lipomatous focus with what look like fat globules, typical adipose cells or adipocytes in what is otherwise recognizable as a meningioma. So this reinforces the prediction or the principle that you can find foci of this odd differentiation in tumors which are otherwise obviously meningiomas. And then on the right is a tumor which is hardly recognizable as meningioma. This is dura, this pink amorphous tissue over here on the upper left. And then all of this is bone. It's mature lamellar bone, but this is not the skull. This is inside the dura, and this is right inside the tumor. This is an ossified meningioma, a metaplastic meningioma making bone. The topic of angiomatous meningiomas is somewhat more complex. Going back to Harvey Cushing, as we do so often, he defined angioblastic meningiomas, but then described in the major monograph with Eisenhart that these clearly fell into three different categories. One of those categories is the tumor which subsequently was split away from meningiomas completely as dural-based hemangiopericytomas. Hemangiopericytoma was the name given to a soft tissue neoplasm, a sarcoma, which was recognized first by Arthur Purdy Stout, one of the famous pathologists of the 20th century, early 20th century. These have now, in the soft tissue pathology, largely been reclassified on the basis of tumor genetics and other studies as either solitary fibrous tumors or various other kinds of sarcoma, including some variants of liposarcoma. So the diagnosis of hemangiopericytoma has largely disappeared from the world of surgical pathology outside of neuropathology. Inside the cranial cavity, these tumors are now more often being called solitary fibrous tumors, which is a name borrowed from a tumor that was originally described on the pleura. And this is interesting because solitary fibrous tumors, as originally described on the pleura, were benign, and we know that these dural hemangiopericytoma-like tumors are in fact malignancies most of the time. And there is an ongoing controversy that remains unsettled among neuropathologists and soft tissue pathologists as to how to classify these dural-based neoplasms, which are clearly not meningiomas, but which mimic them in terms of their growth characteristics, how they grow on the dura outside the brain. Then there's another category that Cushing said resembled hemangioblastoma. And it turns out that some of these tumors are, in fact, true hemangioblastomas, but the dural-based ones, for the most part, are meningiomas which just have a growth pattern and a high vascularity with capillaries that looks like hemangioblastoma. And finally, there's the third category, which are meningiomas which look like meningiomas but have a lot of blood vessels, just highly vascular tumors, which look almost like capillary hemangiomas or cavernous hemangiomas, depending on the individual case. And those are what the WHO now recognizes as an angiomatous meningioma. So here's an example of a tumor which at low power, low magnification, as seen here, looks a lot like hemangioblastoma. It has sort of in between stromal cells that are full of what look like some sort of lipid, and there's an enormous number of small capillaries here. You could easily show this to a pathologist as a single field and get a diagnosis back of hemangioblastoma. But this, in fact, is a hemangioblastoma-like meningioma. And if you look closely, for example, here, just off to the right of center, there's a little meningotheliomatous sort of lobule there, which is more typical meningioma. And there are several of these scattered in this field, and there were more elsewhere in the tumor outside of this particular photomicrograph. Here's what the WHO likes to call angiomatous meningioma. Most of these spaces are endothelial-lined capillaries or dilated venules. In between, there are scant, more typical meningioma cells. These do not have a different prognosis, neither these nor the hemangioblastoma-like ones. They are expected not to recur if gross totally excised unless they have a lot of mitotic activity or are invading the brain, as sometimes happens, and then they're atypical. Now, another variant, and this is one that was not described by Cushing, but was described by John Kepich, are these meningiomas which have cells that resemble those of dermestophytic astrocytoma. For neurosurgeons who interact with their pathologists during the time of intraoperative consultation, when you ask for frozen sections, Here is why it's really critical that the pathologist knows what you're doing before you ask them the question, what is it I've just taken out? Because if you just send this in as brain tumor and the pathologist hasn't had a chance to look up and see where the tumor is, what the MRI shows, and so on, then as a brain tumor, you could look at this and say, these look like astrocytes. This must be some kind of astrocytoma. But in fact, this is a meningioma. It's an extraaxial dural-based neoplasm, and these are meningioma cells. And if you do the appropriate immunohistochemistry, they will stain as meningioma cells. They just look like chemostatic astrocytes with these round nuclei off to the side of a nice little splash of eosinophilic cytoplasm. So that's something to be quite wary of here. Make sure you communicate with your pathologist. Don't ask them, don't tell them you don't want to bias them, just tell me what it is on the slides. Pathologists need to know these clinical factors as they look at their slides. So these are quite rare. I've seen fewer than 5 in my 30 years of practice, but they can be a considerable source of confusion, especially if you send in a small biopsy. And I've seen a couple from the spinal cord where there wasn't a lot of tissue obtained, and this could be quite confusing as to whether these were meningiomas. Which also have the nuclei displaced to the side of the cell body. While the cytoplasm here is also eosinophilic, as in the rhabdoid meningiomas, they don't have the inclusion-like round structures in the cell bodies. Now, it's outside the scope of this talk, which is really about meningiomas themselves, but I should note that there can be other dural-based masses, whether intracranial or intraspinal, which can appear to be meningiomas on CT scans or MRI scans, most often are breast cancers in women and prostate cancers in men. A variety of benign lymphoproliferative disorders, of which the 2 best known and most frequently seen are Castleman's disease and Rosai-Dorfman disease. I'm not sure you're familiar with these as neurosurgeons, but these are benign lymphoproliferative processes. Rosai-Dorfman is actually mostly a histiocytic proliferation, and they can occur as systemic diseases in lymph nodes in multiple sites, but they can also occur as isolated single masses that are dural-based and mimic meningiomas right up to the time that the pathologist sees the slides and says, hold the phone, these are not meningiomas, these are something else. I've seen more Rosai-Dorfman cases than I have Castleman. That may be simply the practices I've been in. I don't know what the relative numbers are. I don't think anybody has a good handle on that. There are other inflammatory processes which can be dural-based, including a variety of granulomas, patients with tuberculosis or sarcoidosis, and also rheumatoid nodules in patients with rheumatoid arthritis. To conclude then, meningiomas are usually among the easiest of central nervous system tumors to recognize grossly by radiology and histopathologically, but they occasionally present considerable difficulty in differential diagnosis, particularly with the individual examples that may closely resemble some other kind of tumor. Familiarity on the part of the pathologist with MRI or CT appearances, so that you know that the case you're looking at is a dural-based extraaxial tumor, can help avoid many diagnostic mistakes. And familiarity with the unusual patterns and variants can also obviously be helpful, and also helpful to the neurosurgeon who gets the diagnosis of something that's unusual in terms of the type of meningioma and needs an explanation from the pathologist exactly what that means and what the prognosis is. Secondly, and a real emphasis here for the clinicians, is that meningioma grading is important to prognosis. It's not something we do as pathologists because we like to divide things up into different grades, but it actually has clinical outcome importance. At present, therapy other than surgery for atypical meningioma is not standardized. So the future may hold new drugs which may inhibit the growth of meningiomas, perhaps acting through the progesterone receptors, perhaps through other means. And this may improve treatment for those tumors when they're atypical, or even for anaplastic meningiomas. But we don't have this today. There has not been a successful radiation waiting for recurrence, or just reoperation for recurrence. And so this is all up in the air and is crying out for someone to organize a large multi-center trial. But this would have to persuade the people involved to overcome their prejudices for or against radiation and randomize patients when they have a diagnosis as atypical meningioma or anaplastic meningioma. Now, while the language of the WHO classification book, as I've mentioned several times, is in places somewhat confusing, the literature does have clear criteria for a diagnosis as atypical meningioma grade 2 or as anaplastic meningioma grade 3, and it's important for patient care that these not be missed because it was, just another meningioma. So studies are ongoing in many places, but certainly, as I've mentioned, I have a study ongoing here with my colleagues in neurosurgery and biostatistics at the University of Missouri School of Medicine. And so these studies are seeking to refine the standardized threshold for atypical diagnoses involving progesterone receptor immunostains, perhaps Ki-67 immunostains for proliferation index, for incompletely resected grade 1 meningiomas, or for atypical meningiomas, or for anaplastic meningiomas. For now, for those of you who don't have access to subspecialty neuropathologists and are dealing with general surgical pathologists, or whose neuropathologists don't have extensive experience in tumor neuropathology, difficult or doubtful cases with unusual diagnoses should be confirmed by consultation with the appropriate experts. And that wraps up my presentation. This last picture is just for show. This is not a meningioma. This is a primitive neuroectodermal tumor. But as some of you will know, the mascot of the University of Missouri sports teams is the tiger. And this is a pattern of growth called spongioblastoma, or spongioblastic pattern in a primitive neuroectodermal tumor. And these lines of cells in this particular case gave us what I think is a fairly nice rendition of a leaping tiger. And with that, I will close this presentation, and thank you very much for your attention.
For the comprehensive and insightful lecture, and I hope you will get questions through the listserv for clarifying any points that the neurosurgeons have trouble with it in this sometimes easy and sometimes complex subject. Thank you very much.
Well, you're welcome, and of course I'll be happy to answer the questions as they pop up.